Good evening, all. It's so happy to see you all here for the scientific session from VIRUDHUNAGAR District Pediatric Forum, a place of crackers. So today we have an explosive speaker, Dr.Sarath Balaji. Indeed, we are very thankful to him. In spite of his very hectic schedule, the academic activities, he has consented to give a talk to us today. Previously, for quite a few years, we used to conduct a physical program in Savagasi, and entire pediatricians from VIRUDHUNAGAR district used to attend in large numbers. And going by the latest trend, so we also opted for online CME so that we can use the expertise of eminent speakers like Sarath without disturbing their activities, daily routine. And they need not come out to Savagasi to deliver their lecture. And the previous session was by Dr. M.S. Viswanathan, gastroenterologist from Chennai. It was a well-attended meet. So today we have Dr. Sarath with us. A very impressive speaker. I am an ardent admirer of his talk. I never used to miss his classes. His lectures in various conferences. He's a senior pediatric pulmonologist from Chennai. Sorry for the spelling mistake there. He is alumni of Tilpak Medical College as well as MMC Madurai. And he also occurred European Diplomate in Pediatric Respiratory Medicine and a fellowship in Pediatric Pulmonology. And he had a brief stint in rural service with so many wonderful experiences that he used to narrate in WhatsApp group about his interesting cases which he saw during his PhD period. And he has been awarded JV Gold Medal for during while he pursuing his MD Pediatrics as well as IAP Active Pediatrician Award in Tamil Nadu State and the Best Paper Presentation in USPIC in 2019. Now he is currently posted as Associate Professor in ICU Chennai. He is also a visiting consultant in MGM Prasanth Amrith hospitals in Chennai. It will take another 10 to 15 minutes to read out his academic achievements. So various laurels he has already acquired, and notably, it's a wonder that he has already done more than 8,000 bronchoscopies so far, and he is in charge of PAD. And you can go through his academic achievements here. He is a co-author as well as a primary author in various textbooks, and he is conducting regularly workshops at various respicons in all over India. He is a most sought-after speaker in regularly in the state as well as national conferences. I hope he will be soon going on an international spree. And these are the publications from Dr. Sarath Balaji. And I am a follower of his social media. His wonderful presentations in YouTube, Pediatrics by Sarath Balaji, and PGs can note it down. Just now you are telling that YouTube is mainly for postgraduates and Insta for undergraduates. You can follow him on a regular basis. He is posting so many academic videos, definitely a good one. So please follow that. It's my strong recommendation. So I am indebted to Dr. Kritika and Dr. Nikhil for the help in conducting this CME. Dr. Nikhil is the backbone of our VIRUDHUNAGAR District Pediatric Forum online CMEs. So many thanks, Nikhil and Kriti, for your help. So let me stop sharing my slide. And over to Dr. Sarath for his presentation.
Shall I start, sir?
Yes, please, Sarath.
Okay. Good evening, teachers, friends, and my dear students. Thanks for the wonderful opportunity again for VIRUDHUNAGAR District Branch IAP. And thanks for my friend Dr. Kritika, Dr. Venkateshwaran sir, and Nikhil. Today's topic is mainly based, as usual, it is mainly based on clinical scenarios. So I'm Dr. Sharath Balaji from Chennai. Right. So when you ask who is the speaker today, he has been speaking about the same TB, asthma, PID, X-rays, ultrasound chest for years together. So what is the thing that he is going to defend himself? The answer is simple. We have a statement from a movie called Mamandan.
நான் பாடிக்கொண்டிருப்பது ஒரே பாடலாக இருக்கலாம். அதை என் வாழ்நாள் முழுவதும் பாடுவேன்.
So let me start the same Thane case scenarios from now. So case 1, so basically as a pulmonologist in ICH and a pediatrician at my clinic, this is about a neuroregressive child. The first case is the travel of a pulmonologist with a neuroregressive child. So look at this child. This is a 9-month-old child born out of non-consanguineous marriage, antenatal, natal, postnatal period, everything turned out to be normal. He was normal up to 3 months. By about 3rd month, the child developed loose stools, which lasted for about 2 weeks, settled on its own, and he was treated for culture positive UTI on outpatient basis. His ultrasound abdomen turned out to be normal. Then the child went for neuroregression, lost eye contact, and totally becomes floppy, not able to roll over, and lost his head control too. When I saw the child by about 7 to 8 months of age, look at the tone of the child. So he's completely hypotonic, not fixing eyes, but there was no microcephaly. Fundus turned out to be normal. Look at the tone of the child. Absolutely floppy. There is no head control at all. By about 12 weeks, your head control should be achieved. Your head should be at the level of the spine. By about 20 weeks, the head should be over the level of the spine. Completely, the child is floppy. So what next investigation do you want to do? Are you going to opt for MRI brain, a tandem mass spectroscopy, genetics, because we have been doing genetics as upfront investigation right now? Or are you going to opt for serum electrolytes or any kind of spinal muscular atrophy you are thinking in terms of? So you can answer in your chat box. Your time starts now. 30 seconds will be given to you. So awaiting your answer in the chat box. What next investigation you are planning to do based on the current scenario and based on a case presentation from a pulmonologist. Whenever neuroregressions occur with respect to interstitial lung disease, often we will be thinking in terms of Niemann-Pick's disease, glycogen storage disorder, and many things. So time up. So let me see the chat box. So there are some answers. Hair shaft examination. Yes, look like albinism syndrome. Fantastic. So she wants to do Chediak-Higashi syndrome, Shriram hair shaft, TMS, MRI brain, genetics, tandem mass spectroscopy, MRI brain. So thanks for your active interaction. Actually, the child went to neurologist first, and almost all investigations were over from the neurology team. So look at this. Lactate was 41. Ammonia, it is hidden here. It was around 100, I think. So ammonia is a little bit high. 100, I don't think it is much of any significance. And this is from the psychology team. And CGC clinic, they said transfer objects, reading out objects, coving everything, query monosyllable. and they had written global developmental delay, little bit of serum ammonia is increased, retina turned out to be normal, and MRI was also taken outside, and MR spectroscopy revealed absolutely normal MRI brain without any active metabolic peak in MRS spectroscopy. And remember, his thyroid stimulating hormone also turned out to be normal. And also his tandem mass spectroscopy was available at the time of examination at my clinic. So still you want to offer some other diagnosis? All the investigations that were mentioned in the chat box were over so far. So do you still want to do any other investigation? Again, requesting your answer in chat box. MRI brain was taken, tandem mass spectroscopy was taken, all normal except the one which was mentioned by Dr. Kritika, hair shaft examination. It was a very good observation indeed. Let me see. So this was written in my clinic, lactate peak, normal myelination of age, MRI, normal metabolic peak. But I was surprised to see a little bit of knuckle hyperpigmentation. Actually, both father and mother belong to Brahmin community, but this child seems to have a little bit of hyperpigmentation. When I was telling and showing this hand to my fellow, he was wondering whether it is really a knuckle hyperpigmentation or not. So when I was telling him, I was suspecting some kind of B12 deficiency, and I hope it should be a B12 deficiency because it is a correctable cause of neuroregression. So someone is drawing something in their iPad. So what is this? Is it? Do you agree with this knuckle hyperpigmentation? To me, compared to their community and compared to the color of the father and mother, there was some kind of knuckle hyperpigmentation, and I ordered only CBC along with the B12. When I was ordering, the mother was asking me, she was well educated, is there any need to take vitamin D? But actually, I did not write vitamin D 25OH-D3. So let me, do you agree with this knuckle hyperpigmentation? How many of you agree with this knuckle hyperpigmentation? Or shall we go for genetics or some other investigations? Do you agree with this knuckle hyperpigmentation? When I told the same to my fellow, he didn't say that it is suggestive of knuckle hyperpigmentation, but at the time I had sent the investigation for serum B12 and CBC. Look at the CBC. So hemoglobin was normal. Look at this, hemoglobin was normal, total count normal, everything seems to be normal, hematocrit, RBC, WBC, platelet. It was we usually think in terms of pancytopenia if we consider B12 deficiency, provided if there is anemia. Look at this, the MCV is 112 and look at the RDW, it is 20. So any high MCV in the presence of high RDW, unless otherwise proved, it is nutritional anemia. When it is associated with microcytosis, it is iron deficiency. Macrocytosis means unless otherwise it is proved B12 deficiency. But there are no, I didn't order for peripheral smear study for hypersegmented neutrophils. But B12 was also ordered in the first visit. So look at the B12 value. It is less than 100 picograms per ml. That a neurologist team failed to identify that a knuckle hyperpigmentation, I think. So what next? So the child was started on B12. Daily course was given for about a week and alternative days for about a week and a fortnight for about 2 months. Right now, the child has been receiving vitamin B12 for the past 2 months in my clinic. So look at this. This is before starting B12 therapy. And look at this. This video was taken yesterday. And they are planned to tonsure his head because they are thinking that the child is doing well. And he started to look into the eyes of the parents, tone increased, roll over, everything is achieved. So what does it mean? Yes, I am a pediatrician, a pulmonologist basically. But before that, I am a pediatrician. So what is the carry home message for all of my students who are listening to this lecture? The answer is very simple. So what is the lesson learned? Case 1, in all kinds of neuroregression, whatever it might be, it can be due to anything. Always try to search for knuckle hyperpigmentation because it is one of the easiest thing to correct. So instead of looking for so many blood investigation, try to identify the findings in our child based on the physical examination. We all know that Srinivasan Raghavan used to infer each and every time there are so many correctable causes for inborn errors of metabolism. Almost 4 to 5 to 10 diseases can be treated by giving simple vitamin supplements, whether it is pyridoxine, thiamine, riboflavin, B12, etc. So case 1, it is a case of neuroregression, and the knuckle hyperpigmentation has been missed, and instead many investigations were proceeded. So again, kindly look for knuckle hyperpigmentation and take a CBC. Definitely it will give you so many clues towards the diagnosis. This is about case 1. Second case. So what is this case? Yes, we are running a primary immunodeficiency clinic at ICH. Pulmonology department is in charge of it. This is about a 7-year, might be around 8 to 10-year-old girl child who is known case of hypogammaglobulinemia, a selective IgM deficiency. In fact, a very, very rare one indeed, even among PID group. So she has been receiving monthly immunoglobulin for the past 7 years. And this child presented with fever of about a week with hepatosplenomegaly. So what will be your thought process? So look at this. This is a 10-year-old girl, selective IgM deficiency on monthly IV immunoglobulin for the past 6 years. On and off she used to miss, but majority of the time, at least 6 to 7 months per year, she used to get monthly IVIG. And she has been suffering from fever for the past 7 days along with hepatosplenomegaly. Look at the count, leukopenia, hemoglobin was relatively normal. Yeah, platelet count was 1.2 lakhs, a mild thrombocytopenia. LFT normal, culture awaited. So what will be the ideal drug of choice in this scenario? So 7 days fever, based on 7 days fever, skipped immunoglobulin in the last month, now presented with fever along with hepatosplenomegaly. So culture is awaited. Before that, what could be your drug of choice? Peptas, amikacin, gram-negative organisms. Leave it, whatever it may be. If the child is sick, invariably we tend to give Miro-Vanco nowadays, whatever it might be. Fever more than 1 week, give Miro-Vanco. Connective tissue disorder, no, try Miro-Vanco. That is the dictum in many places. Or else, as a primary immunodeficiency, do we need to rule out tuberculosis? Or look at this, hemoglobin is normal, but total count relatively low. Platelet relatively low. So can I suspect malignancy? Can I suspect TB? Or shall I start oriconazole, thinking that this immunodeficiency is prone for prone for viral, prone for fungal, but this is basically a B cell deficiency, which often is getting infected with capsulated microorganism. So your time starts now. In this scenario, what would be your drug of choice till you wait your culture results? Again, waiting for your answer in chat box. Your time starts now. You can answer whatever it is, right or wrong. Even I made a mistake in this case particularly. Rule out TB because we run voriconazole. D, rule out malignancy. Yes, thanks for your Solai Kumar, very good. Miro Vanko. So to be very frank, in the background of immunodeficiency, that too the child had a missed immunoglobulin in the last month. So invariably, I was thinking in terms of an invasive pneumococcal or Haemophilus influenza. So for that, ceftriaxone would do. But in the background of an immunodeficiency, invariably, even I was thinking in terms of Miro and Vanco. But what happened actually, my fellow Dr. Karthikeyan and one of our postgraduate, I think Dr. Kalyani, had picked up this finding. What is that finding? Look at this. What is this? Now the answer is so obvious. So what is the answer? So this is an SR. The child was started on doxycycline. She went home within 3 days of treatment, and the treatment course was completed. So what is the lesson learned in this case too? Again, what is the lesson learned? The lesson learned is, even in the background of immunodeficiency, why don't you suspect a common tropical infections like malaria, dengue, enteric fever, scrub, lepto, etc.? So instead of thinking about an underlying background of primary immunodeficiency, always think in terms of infections in the places where you are living. So again, I repeat, whatever it might be the case, the child might be on a rheumatological disorder, a child might be on a disseminated TB, child might be on immunodeficiency, child might be on inborn errors of metabolism. Whenever any child comes with fever of more than 1 week, think in terms of an underlying common tropical infections of your community rather than thinking about the background history. Again, in a country like India, before starting an antibiotic, kindly examine for all flexural areas to look for SR. Again, to be very frank, I would have started the child on ceftriaxone. My fellow and my postgraduate only picked up this SR. Again, carry home message is, expect common infections, tropical infections, even in the background of primary immunodeficiency. This is case 2 and lesson learned. What is case 3? So this is quite interesting. What is this case 3? Recurrent seizure in a 2-year-old child with a recent contact with TB. The child was on inhaled corticosteroids, and I think one of their relative, I don't know whether it is maternal uncle or something, developed TB. So the parent brought the child for screening of TB and to start INH prophylaxis, but there was a finding in the X-ray. So what is this finding? Let me show you. So the background is 2-year-old, apparently normal so far, on ICS with recent contact with TB. So let me show you the, so 2-year-old recurrent seizure, weight appropriate for age, on inhaled corticosteroids. Now contact mother on ATT, brought for INS prophylaxis, Manto negative, but in X-ray chest. So let me give you again 30 seconds, your answer please. So what is the thing that is obvious in this X-ray? Your time starts now. Background, you know, look at the X-ray and think in terms of the underlying background history. So let me start the timer. Thank you. Okay, those who had answered are my postgraduates and they knew the case. So whenever we see the X-ray, invariably we will concentrating on the heart and we will be concentrating on the lung.
I was the first one to answer, sir.
Pakala, sir. Extremely sorry, sir. Okay. So what happens? Invariably, we'll be concentrating on lung and X-ray chest. So, but remember, we need to look into the upper end of the humerus. I repeat, we need to look into the upper end of the humerus, which can have, look at this upper end of the humerus has got fraying of upper end of the humerus. It doesn't mean that you need to have widening. It doesn't mean that you need to have cupping. The earliest finding is fraying of humerus. So whatever it might be the X-ray, whatever it might be the cause for which the X-ray is taken, it is our responsibility of the pediatrician to pick up this rickets in particular, because majority of our children are not playing in outdoors. They are actually playing with their mobiles, iPads and iPhones. So that's why we have been seeing a surge of rickets cases post-COVID in particular. So what is the carry home message? So the carry home message is, so actually at any cost, pediatrician should not miss early features of rickets in bones and in all available X-rays. Always look for upper end of humerus for fraying and anterior rib widening. If you miss rickets in any of your chest X-rays, it means you are missing what Dhanush was missed about her girlfriend. So he was looking into the heart and the lung in chest X-ray, but the finding was something different. So we can say, நம்ம பார்க்கிற பொண்ணு பையனுக்கு பின்னாடி தான் நம்மள பார்க்கிற பொண்ணோ பையனோ இருப்பாங்க. So always look into the bones in any case of X-ray chest, apart from looking into the lung and heart. So let's go to the next case scenario. So what is this case? This is a case of cough variant asthma, referred to my clinic last month. So what is this case? This is a 10-year-old boy. Actually, it was a girl, 10-year-old girl, cough for the past 1 month, no fever and no weight loss. So it is literally ruling out your TB. X-ray chest was taken normal, CT chest was also taken normal, CBC normal, and the child was having significant nocturnal cough. At times dry, at times wet. So it is confusing whether we need to think in terms of a protracted bacterial bronchitis, what a pulmonologist used to diagnose whenever there are no constitutional symptoms like fever, weight loss, and wet cough lasting for more than 4 weeks. But what happens? The child was nebulized. The mother said response to salbutamol was present. When the child came to clinic, the child had already received ceftriaxone for 10 days. On admission, dexamethasone was given, azithrol was given, oseltamivir was given, and referred by the treating physician as a case of cough variant asthma. So what should I do now? Shall I start inhaled corticosteroid? What next thing would you like to do? So your time starts now. So I think the answer was revealed to my postgraduates in the last class. So better not to answer. Let me see others options. So your time starts now. There is no fever. There is no weight loss. Child had been treated with the ICS trial, pulmonary function test, vaccine history, 10th year, yet to be given vaccine for what? Okay, your time is going to end. So what should I do right now? Okay, any allergy at home? Again, majority of the times, we will be thinking in terms of the investigations taken by the referral physicians. So what is this? The child has been suffering from cough for the past 1 month, and all investigations and all probable OP drugs were given. So if it is a wet cough, as we discussed already, lasting for more than 4 weeks, I could think in terms of a protracted bacterial bronchitis, and I can treat the child with amoxiclav for more than 2 to 4 weeks. But zone was started, dexamethasone was given, azithrol given, oseltamivir were given. What else I should go for? All investigations also turned out to be normal. He had covered all possible drugs are for all possible common microbes that we see in our OP practice. So what should I do now? So I was asking the mother about each and everything, so many confusions with respect to their history. They said something, but I could not understood what they are trying to say. But finally, what I did to that Muslim child, you cough, let me see. So look at the child coughing. So now the diagnosis is so obvious. So what is the diagnosis? The answer is obvious. So again, this child came to clinic almost 6 months back. Again, the same pattern with this kid. Look at this kid. Yes. So what is the carry home message from these case scenarios? We often miss pertussis in our day-to-day practice, 100% damn sure. We will be thinking that giving macrolide would have cured the disease, but how early you are giving macrolide, let me know. Because the diagnosis of pertussis is often missed unless otherwise that kind of paroxysmal cough occurs in front of you. That's why whenever a child who has been coughing for more than 2 weeks, let me ask only one question, whether it is a dry cough or wet cough. Wet cough means definitely, like you, I would have been thinking in terms of an amoxiclav. But if it is a dry cough and a little bit of older children, I will ask that child either in ICH or in my clinic to sit for about 1 to 2 hours, so that definitely I will get that kind of paroxysmal cough. Definitely. In case in this particular child, usually we will be asking some history. Innapa kannala thanni varudha, moonji redda avudhan, we will be asking. But despite asking so many times, the mother of this Muslim child denied the fact of redness of eyes. So just before sending the child, I told her, let you cough. So let me observe. So when she started coughing and the diagnosis was pertussis was made, I did not do any investigations for both of them. This child went well with the macrolide, but this child I would have opted for levofloxacin because to be very frank, I am not supposed to say this statement. I have been personally observing resistance of mycoplasma and resistance of pertussis to macrolides, because left and right people are using macrolide. So this child went well only after levofloxacin, but this child responded very well to azithromycin itself. So what is the carry home message? Again, this child, I saw him a year back. Look at this. So there is no need for any investigations indeed. So what is the carry home message for my students and for my postgraduates and for my friends? In any case of dry, distressing cough, in all adolescents, rule out pertussis by asking 4 simple questions. PPTR, paroxysmal, திடீர்னு வந்து திடீர்னு போதா, post-acute vomiting, இரும்பி வாந்தி எடுக்கிறியா, so இரும்பும் போது கண்ணுல தண்ணி வருதா, மூஞ்சி ரெட் ஆகுதா. So even though this tears from eyes and redness of face were not included in WHO criteria for pertussis. What does WHO criteria says? Cough more than 2 weeks along with paroxysmal post-tussive vomiting, whoop in newborn or in young children, you can have apnea. This is the WHO criteria. They did not mention about tears of eyes and redness from face. This is so sensitive and easy to pick up rather than asking questions regarding paroxysmal and post-tussive vomiting. So I used to teach my students whenever there is nocturnal cough between 12 to 4, always think in terms of a cough variant asthma. But before starting inhaled corticosteroids, let me rule out pertussis clinically in case of young children through PCR studies. Okay, if I am not satisfied with other points while starting inhaled corticosteroids. Right, so this is about scenario 4. Lesson learned 4. Dry distressing cough, adolescent age group, always rule out pertussis, and simultaneously all these children were started on Tdap vaccine 2. Right. So case 5. This is a case of B cell ALL. We had a very tough time in this case while dealing with this case. So what is this case? This is a case of B cell acute lymphatic leukemia along with persistent lung infiltrates. Almost we spent around a month or 2 before that before the diagnosis are made, before some consensus statement were established by our team, including hematology. So what is this? So this is a 4-year-old boy on chemotherapy for B cell ALL. Okay, he has been doing fine with respect to, but invariably, whenever I see any case of B cell ALL on chemotherapy, invariably their counts are literally low, unless otherwise, but without any blast cells in marrow or in the peripheral smear study. I didn't want to go deep into it. So he had completed 1 year of treatment. Right now he is in the maintenance phase. The child was started on ATT. You might be asking why ATT for this child. So the child has been coughing a lot with some weight loss. His manto turned out to be positive. There were, even though there are no TB specific shadows, we were forced to start ATT. We are literally forced to start ATT, but it happens. Okay, in the background of immunocompromised child with persistent cough, even though whether you are getting CB naught and culture or negative, at times even in our institution, we will be forced to start ATT with some poor background. Okay, the child was started on ATT, but manto turned out to be positive, and the father was confusing us. There was a doubtful contact, and he has been in ICH for about months together. Even though there are no TB specific lesions in the X-ray. Look at this. The child was on Miro, Vanco, Septron, Oriconazole, ATT. And for a pulmonologist, convincing thing is round shadows here, round shadows are there. So left basal, left paracardiac, round shadows are there. Whenever we see these kinds of round shadows in the context of immunocompromised state, we will be thinking in terms of fungal unless otherwise proved. CT was taken suggestive of fungal. We did ball culture, turned out to be negative for fungal infection. Despite that, since the child has been worsening, we were supposed to continue, we are forced to continue each and everything. So what should we do right now? We did so finally we had a great confusion what to do and what not to do. Our new hematologist Karthik, who had completed his DM fellowship and he recently joined our department of hematology, and he was ex-student of ICH. He told, let us do bronchoscopic lavage and sent the sample for PCR and other studies, and he made some sponsorship because culture turned out to be negative. So invariably, we were more thinking in terms of PCR related thing. So look at this. Cytomegalovirus was 50,000. And Aspergillus galactomannan, culture turned out to be negative for KOH mount as well as your fungal culture. But Aspergillus galactomannan turned out to be positive. Cytomegalovirus virus turned out to be 50,000 copies. Look at this. The child was already on Septron, already on Oriconazole, ATT. What next? So now, what next? Now tell me, can we give importance to this cytomegalovirus? Can I start valganciclovir or ganciclovir? Shall I stop oriconazole and start amphotericin B? Shall I start a DRTB empirically, or shall I go for capsofungin? Because galactomannan turned out to be positive. So when I was discussing with, so your time starts now. So what will be your mode of management with this background? Your time starts now. Anyone can answer. HIV ruled out. Any way of confirming microbiologically, we tried our best. Microbiological turned out to be negative. We tried our best. CBNA turned out to be negative. MGIT turned out to be negative. Waiting for some more answers in this background. That's all. Okay. So our hematologist wanted to start ganciclovir for cytomegalovirus, but we have personally seen copies of lakhs, millions of cytomegalovirus in PID patients, KIT patients, and other children on immunocompromised state. So I was literally discussing with cytomegalovirus copies with one of my friend, ID specialist. She told definitely don't give importance to this 50,000 copies. Less likely be due to cytomegalovirus. Again, like Tirisanga Surgam, we didn't know what to do. So look at this. What to do now? But later on, we made an audit by ourselves and find out the following one. Look at this. The child was on multiple drugs. So is it possible to get an answer? I am giving you a clue. The child was on multiple drugs. D. Ganciclovir. The child was on multiple drugs. So this is the clue. So remember, your ATT is a potential, particularly your rifampicin is a potential enzyme inducer. So finally, what we did, since this potential enzyme inducer had inactivated the oriconazole levels in the blood, that's why the child was not responding. So what the team decides, the team decided to stop ATT. Okay, despite some request, we will start ATT, stop ATT, and let us proceed only with oriconazole. And to our surprise, within 4 to 5 days of stopping ATT and continuing the same oriconazole, the child had come up well, both clinically as well as radiologically. So what is the carry home message in this case? The carry home message is very, 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 very simple. When you have a pattern recognition, and when you start treatment based on the pattern recognition, based on the culture results, but if it doesn't work, always think in terms of drug interactions. And there are many papers. Look at this. Induction of oriconazole metabolism by rifampicin in a patient with acute leukemoid reaction. So acute myeloid leukemia. Look at this. There are so many papers. So always again, case report demonstrate a drug-to-drug interaction between oriconazole and rifampicin after discontinuation of oriconazole. The child has been doing fine. So again, I had one more case called Pooja Lakshmi, a 10-year-old child brought with abdominal distension, fever, cough, weight loss. She was walking to my clinic. I started her on ATT based on the culture result that was disseminated TB. So based on the culture results. So when I started her on ATT, first 40 days she has been doing fine. But on the 42nd day, the child suddenly started limping. The child suddenly started limping. And we took MRI, so many investigations, MRI, and she was telling back pain, okay, lower sacral pain, and she felt very, very weak. And when we started our very, very weak, the child was admitted. Extensive investigations has been done, including bone marrow. Bone marrow did not reveal any blast cells. Bone marrow did not reveal any granulomas because it was a case of disseminated TB. Finally, a simple vitamin D level was done. It was turned out to be just 3 nanomilligrams per liter. So just 3 nanograms. So finally, she was started on vitamin D and discharged. The mother came and asked me, sir, why suddenly this vitamin D has gone to a great low level? And she herself offered, sir, na refer panna ATT kutta vitamin D kammi aguman. So I made her to sit, referred the same rifampicin can produce hypovitaminosis. I told her, yes, it is brilliant. And this topic was given to one of our postgraduate as a thesis topic because ATT induced hypovitaminosis D was given to one of our postgraduate as a thesis topic. So what is the carry home message? Always give importance to drug interactions, which we have not been giving so far. So lesson learned 5, drug to drug interactions to be considered when there is no response despite drug sensitivity and despite correct diagnosis. Multiple drugs, drug interactions, multiple drugs, fever not responding could be due to drug fever. Recently, we had 2 cases of immunodeficiency. No focus on many drugs for about days together. When we stopped the drug, the child went well. So drug to drug interaction and drug induced fever should be considered, should be given importance. Right, this is about case 5 and lesson learned 5. Case 7. So what is this? Case 7.1 and case 7.2. Let me see what is this. So this is a 3-month-old child, respiratory distress since birth, non-toxic child. So with the reduced air entry on one side, I think it will be very, very easy for you to answer if I show you the next slide. So what is this? Yes, you can answer. The answer is very, very easy. So what is the answer? 3-month-old child, respiratory distress, air entry reduced on one side. Yes, it is. Yes, the answer is very, very easy. What is this? This is a case of many had answer. Look at this. There is emphysematous lung on the left side. So look at this. There is emphysematous lung on the left upper zone. Mediastinum is pushed to the right. There is collapse on the left lower zone. And it was shown, it and the CT revealed the same. The left lung is emphysematous. As you all know, this is a case of congenital lobar emphysema. Look at this. This is the coronal section. Again, it shows emphysema involving the left upper lobe and some kind of GGO changes on the left lower lobe because it can be due to the pressure effect of the left upper lobe. Yes, you do see these cases of cases with clear-cut definitions like A plus B whole square. It will be very, very easy. A newborn with the emphysematous lung, with the respiratory distress, reduced air entry must be due to congenital lobar emphysema unless otherwise proved. But in this background, and we have been seeing many cases of congenital lobar emphysema, in the next month, you could see these kind of cases too, 7.2. So I have 7.1 on your background and look into this 7.2. So this is a 3-month-old child. This is a 3-month-old child, respiratory distress for the past 3 days. Just 3 days, I repeat, 3-month-old child. Just 3 days. Again, what is the diagnosis? 3 months old, air entry reduced on the left hemithorax. Air entry reduced on the left hemithorax, 3 days history. Requesting your answers in chat box. Your sagittal is given, axial is given. Sorry, coronal is given, axial is given. What is the answer? Foreign body, mediastinal mass, left emphysematous lung. Mediastinum is pushed to the right. CT in the previous case, axial and coronal were shown in the same way. In this cases, both were seen. Is there any other thing apart from emphysema in the CT cut? Awaiting your answer. You don't require much of the CT knowledge to pick up certain simple findings. Mediastinal mass, right lung. If it is a mediastinal mass, there should be shift of the mediastinum trachea to the left, but there is no shift. But you are correct indeed. Is there anything? So let me, look at this, the trachea as, look at this trachea here, trachea here, trachea here. Trachea definitely here, lower end trachea has got some extraluminal compression. Okay, as Dr. Kritika told, and this is uniformly emphysematous lung. Look at this cut. What is this on the CT left side? What is this on the CT left side? What is the simple? Whenever you have a white background, in that if you see a black colored thing, what is the simple diagnosis you can offer? Very simple. What is this called as? Consolidation. Yeah, consolidation, okay. Inside the consolidation, if you have a black thing that too chronic, what will you call it as? You can call it as either nematocele or cavity. And this background, okay, and in this background, look at this extraluminal compression, probably due to mediastinal mass bar nodes, but this one was surprising for us. Why this cavity in this such a young child? So surprisingly, we did bronchoscopy. Bronchoscopy mainly to look for extra compression, to look for extraluminal compression of left main bronchus by the emphysematous lung. But surprisingly, we could pick up cheesy material in the left main bronchus, along with this cavity, which we did not expect. The sample was sent for analysis. Turned out to be a case of TB, pulmonary TB with the mediastinal nodes mimicking as CLE with short duration as per the mother. The mother told only 3 days of respiratory distress. I asked her repeatedly. So what does it mean? So not all neonatal respiratory distress with the emphysematous lung are congenital lobar emphysema. Beware of the mimics. When one lobe is emphysematous, yes, it could be congenital lobar emphysema. But when the entire lobe is emphysematous, think something else. Okay, think something else. We had cases of bronchogenic cyst pushing the carinal bronchogenic cyst, compressing the left main bronchus, presenting as emphysematous entire left hemithorax. So always beware of the mimics. Okay, right. Then the next case 8. This is a simple spotter. 7-month-old child referred a year back as a case of pyoderma gangrenosum from Krishnagiri. So this is not ICH case, private case. So look at this. Look at this. Look at the ecthyma gangrenosum and it is Pseudomonas positive. So what will be your next investigation of choice? What will be your next investigation of choice? Your time starts now. You can post your answer in chat box. The question is, what is your next line of investigation? Next, not what is the investigation of choice. What is the next line of investigations? The child has been receiving many drugs, not responding to it. The child was treated appropriately with anti-pseudomonal drugs based on the culture and sensitivity. What is the answer? Time up. So let me see the chat box. So what are all the options? PID workup, CBC, peripheral smear study, phagocytic disorder. Yes, you people are damn on target. So this is a case of non-healing ulcer. Remember, whenever you see a case of non-healing ulcer in a newborn or in a young infant, always think in terms of phagocytic disorder. If it is a chronic granulomatous disease, it could be due to abscess, node, pus formation. If there is no pus formation, think in terms of leukocyte addition defect. For both leukocyte addition defect and chronic granulomatous disease, your counts will be very high. What I teach my students are an absolute neutrophil count of more than 25,000 and the child not responding to treatment means think in terms of these zebras, your leukocyte addition defect and chronic granulomatous disease, because the count will be very high. But instead, in this case, what had happened? So instead, in this case, look at this. This was taken in Krishnagiri. This was taken in Krishnagiri. Total count just 10,000. There is no leukocytosis. Then what will you ask for? Neutrophilia. But the neutrophil count is just 5%. The lymphocyte count is relatively normal. There are many investigations with the child. I told one of my PG to document the absolute count rather than going for the percentage. So Saravanan, that particular PG documented this. Look at this. 8th month of 2001, the neutrophil count is damn low. As well as one more value, 2021, other values are relatively normal. Look at this, absolute neutrophil count are relatively normal. But this time the child was admitted. Other times the investigations were done on OP basis for simple common cold. Again, in the month of July 2022, total count was 13,000, but your neutrophil count was just 100. At that time, the child came to us with this kind of non-healing ulcers. Told my PG to write what are all the organisms that could be that were retrieved. It is Staph aureus and Pseudomonas. So again, what is the carry home message in this case? Any non-healing ulcer, I repeat, any non-healing ulcer in pediatric age group, in infants particular, it can be due to neutropenia or it can be due to leukocyte addition defect. Even many papers in which neutrophilic defects such as leukocyte addition deficiency were manifest as ecthyma gangrenosum like ulcer or non-healing ulcers. Think all these things. Again, it doesn't mean that you need to go for costly investigations like genetics. Almost majority of your diagnosis can be sought through CBC, peripheral smear study, LFT, RFT, all common investigations that were invented even before 2000. Here, the case was picked up. It is a case of not neutropenia, not just neutropenia. It is a case of congenital cyclical neutropenia. The child was given GCSF, a relatively little bit of improvement with respect to the ulcer. And again, the child lost to follow up. the plastic surgery were also planned because this entire area were sloughed. So we wanted to audit ourselves whether these rare diagnoses were correct or not. You must be asking lad. For lad, it is the counts are very, very high, sky high. Here the count is low. And we did genetics. Look at this. Genetics turned out to be, look at this genetics. JAG1 mutation, neutropenia, congenital, severe, homozygous. So it is not that tough to identify cases of primary immunodeficiency in your OP practice. Just a simple neutrophil count, less means neutropenia, more means phagocytic disorder. A ALC in any infant less than 3000 could be skipped. Recently, we had a case of hepatosplenomegaly with eczema with a very high cell count. And we were thinking in terms of ALPS, but finally it turned out to be a case of Viscott-Aldrich syndrome. So any child with hepatosplenomegaly, infection is not there, suffering from birth, it doesn't need that mean that you need to have eczema, something. That child turned out to be Viscott-Aldrich syndrome by genetics. And again, any eczema not responding to your steroidal creams, along with the associated very high eosinophil count, think in terms of hyper IgE syndromes. And what is this case 9? This is 7-month-old child, persistent fever. Look at this, 7-month-old child, persistent fever, progressive hepatomegaly. So what is this case? Do you find any other clues in this child? What is this? 7-month-old child, persistent fever, progressive hepatomegaly. Is it an immunodeficiency? Is there any clue with respect to ANC? Normal. ALC, normal. Anything, any organism is retrieved? None. But slowly, monthly, the child has been suffering like anything. People have already ruled out TB outside. When we saw the child, at ICH, not to our department, the child had hepatosplenomegaly. Hepatosplenomegaly, along with that, look at this seborrhea. The child had seborrhea. Look at this, the child had seborrhea. Along with that, some hypoechoic lesions in the liver, spleen, and pancreas. So, this is the scenario. X-ray turned out to be normal, except this hypoechoic lesion in the liver, spleen, and pancreas. CV not also done outside turned out to be negative. The hypoechoic lesions in liver, spleen, pancreas. The child went to hematology. The child went to pediatric surgery. Look at this. They did PET CT scan, numerous lesions in the liver, spleen, pancreas, some nodes in mediastinum also, along with that osteolytic lesions in the vertebra, osteolytic lesions in the body, and hypoechoic lesions in the liver. The report was Langerhans histiocytosis more in favor. Now let me give you another 30 seconds. What is your next investigation of choice? I repeat, what is your next investigation of choice? Looking for answers. Ferritin. Paniraman Anna, you are there. Biopsy. Okay. Biopsy was done. Can you tell me what could be the probable biopsy finding? Probable biopsy finding was caseating granuloma. And we did, with this report, the child had brought to our department. Already CB0 was done. We did ball CB naught again, turned out to be negative, but we did Manto, turned out to be positive, and the child was started on clinically diagnosed disseminated TB. That surgery team failed to send the sample for microbiological evidence. This sometimes can happen. They didn't send the sample for microbiological evidence, but we started the child on, 1 second. Hello. Hello. I'm sorry. So the child was started on ATT. The child has been doing well. So what is the carry home message? Multi-system involvement in India is TB unless otherwise proved. Radiology often assists you. Histopathology often guides you. Microbiology often confirms with respect to TB. Do not forget these common scenarios in our day-to-day practice. Finally, case 10, a 10-year-old child, persistent fever, cough 6 months, weight loss 6 months, along with hepatosplenomegaly. So this is the scenario, the undernourished child, pan-digital clubbing. Look at this, pan-digital clubbing, coarse crepitation, left lobe of liver is enlarged. It is often a general teaching. Whenever left lobe of liver is enlarged, it is a case of liver cell cirrhosis. Splenomegaly was there, hypoalbuminemia was there, ESR 100, CRP 100. Look at the X-ray, left to lower lobe is completely destroyed left to lower lobe. So now tell me what will be your next investigation of choice. We are awaiting your answers in the chat box. Cystic fibrosis, one of our fellow Tejaswini opted the diagnosis for cystic fibrosis. Sir, it can be due to heterozygous variant. One more answer, TB, CB naught, CF again, CVID. Fantastic answers, fantastic answers. Because we often don't get clubbing now. We often don't get clubbing in TB cases, but this child had clubbing. Why can't, even myself was thinking in terms of why can't it be a common variable immunodeficiency with kind of autoimmunity destroying the liver, leading to left lobe of liver enlargement, common variable immunodeficiency more prone to produce bronchiectasis. This is how we thought. We proceeded confidently. Tuberculosis. Okay, one of our delegate had answered, but look at this. CB not negative, Manto negative. Cystic fibrosis with liver involvement, sweat chloride negative. CVID common with any girl child with bronchiectasis, kindly do immunoglobulin profile. But IG profile turned out to be normal. We were thinking in terms of whether it is a case of primary ciliary dyskinesia. But to all our surprise, HIV turned out to be positive. None of you had answered for HIV. That bronchiectasis, everything was due to HIV. We sent the sample when CB naught was negative. We sent the sample for MG80. Look at this. Look at the MG80 result. The MG80 culture. Okay, results available, culture positive, MTB detected, R sensitive, H sensitive. So what is this case actually? What is the carry home message in this case? Lesson learned, very simple, multi-system involvement across world. Rule out HIV first. This is the third time I am doing the same mistake in the past 14 years. Do not proceed for any other investigation before doing an HIV test. Second, send samples simultaneously for culture. Okay, either it is apart from CB naught, either it can be a LJ or it can be an MG80, because Whenever your CB naught misses, it can be picked up by culture. These are all the carry home messages from these two cases. Never ever forget to do an HIV test. So, right, case 11, 5 years old, recurrent cough, asthma qualifiers, doubtful. This child was referred from Andhra. Bronchitis is brought by grandmother with the brilliant technique and very good compliance, very good technique, everything. But bronchiectasis in HRCT, ABPA negative. Look at this. This is the discharge summary from our team. The child did not have any failure to thrive. Points in favor of asthma, nocturnal cough, response to bronchodilator, exercise limitation, sweet triggers. When we were repeatedly asking dry cough only, the party was telling us. But points not in favor, a little bit of resting tachypnea. Fractional excretion of nitric oxide is less. Poor control despite being on 4O cart. Aspergillus turned out to be negative. Some form of signet ring, that is bronchiectasis, early forms has been started. It was turned out to be a neutrophilic ball. So what was the discharge summary? At present, no features of PCD, PID, CF or aspiration. What is the red flag that we had mentioned? Persistent tachypnea in the absence of cough, bronchiectasis in CT chest, neutrophilic ball. Since it is neutrophilic, we started the child on azithromycin prophylaxis, and my fellow told the child had little bit of improvement with omeprazole. It was started and the child sent home. But before that, we sent the we had opted for genetics. There were no oily stools, no upper lobe involvement. Aquagenic turned out to be negative, but look at the report of the genetics. CFTR positive, heterozygous, even though it is said uncertain significance, we were more in favor of heterozygous CSF, because if it is homozygous, we could have got that kind of robust presentation with upper lobe involvement, bronchiectasis, pancreatic insufficiency, etc. So heterozygous CFTR do present with these kind of confusing complaints that we are going to see in near future. And the last case 12. So again, Bhumika, 12-year-old child. Bhumika, 12-year-old child. So look at this, for 12-year, weight was absolutely fine. Apparently normal just before 3 months. Contact, none. Family history of atopy, none. No previous SNP, none. Wet cough for the past 4 months, and there is on and off fever. Asthma qualifiers like exercise intolerance, emotional cough, nocturnal cough was present. Tonsil present. Look at the findings of my no hypoxia, no clubbing. Immunoglobulin profile turned out to be normal. I did skin test, turned out to be sensitive to cockroach. Albumin normal, globulin normal, CB not negative, neutrophilic. There is no neutrophilia or eosinophilia. Some gram-positive cocci in sputum. Some improvement after ICS. So there was ABPA diagnosis was offered. Atypical asthma was offered. So can you tell me what other thing that was hidden behind this blue bar? What hidden history was behind this blue bar? What hidden history was behind this blue bar? Can anyone mention in the chat box? So one particular history I could make out. What is that history? Rhinorrhea since birth, but there is no autoria. So since there was rhinorrhea, since birth, you are less likely to get rhinorrhea. You might get sneezing, but rhinorrhea, how could you get? So rhinorrhea since birth, but wet cough only for the past 3 months. So my provisional diagnosis, despite not having that kind of severe bronchiectasis, my diagnosis was evolving PCD. So we did all investigations, turned out to be normal, ordered for genetics. Look at this, ordered for genetics. Look at this, some kind of mutation, likely pathogenic, primary ciliary dyskinesia. So what is the carry home message? Whenever you get a wet cough that lasts for more than 4 weeks and not responding to your course of amoxiclav or recurring again and again, By and large, do immunoglobulin profile. Do not, but in case of hypogammaglobulinemias, you will be suffering from some kind of bronchiectasis. But here in this case, anthropometry was normal, but there was no atoria, there was no situs inversus totalis, but the only clue I could get is rhinorrhea since birth. So the diagnosis turned out to be primary ciliary dyskinesia. We have been diagnosing so many primary ciliary dyskinesias with less penetrations. It doesn't mean that you need to have all these things, because each and every disease has its own spectrum. So on one hand, you can, even viscotolid syndrome do present with the microthrombocytopenia alone, do present with only eczema. In the same way, do not expect atoria. In our cohort of 13 patients, we have seen only one case of atoria, because it is a general thought that the difference between CF and PCD is upper respiratory tract in the form of persistent atoria. But here, many cases are presenting with insignificant penetration or poor penetrations of the gene, manifesting as wet cough. Wet cough, recurrent, not responding to your antibiotic, middle lobe involvement, immunoglobulin profile is normal. Damn sure it is cases of PCDs. We have been seeing numerous PCDs, numerous CF, many heterozygous, homozygous also. In a country like India with 150 million population, the so-called Caucasian diseases are becoming rampant here too. So this is the lesson learned from the last case. So when pattern doesn't, so from 11th and 12th case, what I learned, when pattern doesn't progress to identify a disease, do not hesitate to go for genetics, but you need to have a pattern recognition. Okay, proceed for genetics, no issues. So finally, what is the carry home message for my students who are listening? Always don't forget to audit old discharge summaries. One of my patient showed 2010 antenatal ultrasound which showed CCAM, but the child presented at 2020 with pneumothorax, and on healing, cyst was there in the right upper lobe. We were thinking in terms of staphylococcal cyst, but when we audit the old summary, we concluded it is a case of CCAM and it was removed. 10 years old discharge summary, that one. Always audit old discharge summaries. Carry home 2, close your eyes and listen. Majority of the time, mothers will give you answer. Caretakers will give you answer. Open your eyes and closely look at the baby, not the mother. The first child, the neurologist team had missed the knuckle hyperpigmentation. Okay, it doesn't mean that the same thing can happen to me also. In a busy practice, definitely we tend to forget all these things, but it is mandatory. And simple clinical maneuvers. Majority of the time, any callovers were given for persistent pneumonia, recurrent pneumonia, 3-month-old child, 2-month-old child, not responding to antibiotic, to rule out PID. When we saw almost many cases of floppy infant, turned out to be myopathy, muscular dystrophies, spinal muscular atrophies, and central hypotonia. So many things with frog-leg position that were being missed nowadays. Only role of stethoscope as far as pulmonology is concerned is to find out reduced air entry or monophonic wheeze to identify a foreign body. Rest stethoscope is not at all necessary. In clinic, it is mandatory because you need to get a fees. CBC, yes, it will reveal so many PIDs, RFTs, LFTs will give you whether it is a CF or not. Electrolytes, again, it will give you. Any anemia with elevated urea creatinine could be due to a normocytic normochromic anemia of a CRF. Smear studies, yes, in this case, congenital neutropenia had revealed one important clue. So these simple basic investigation often offer valuable clues which we are missing or overlooking nowadays. Do not hesitate to do CT chest or MRI if pattern doesn't work. Microbiology matters. In case of any doubtful lesion, send for fungal, send for gram staining, send for culture. It can be bacterial, fungal, anything. And in the present era, always send samples for PCR too. Okay, when it doesn't, when you are not going with the routine antibiotics and the child is not responding, multi-DOF, a new culture method based on 16S ribosomal RNA. Yes, you are in the era of genetics. Make use of it if it doesn't work with your pattern recognition. And finally, you can forget all these things and still you can be a good practitioner if you are a good communicator. You can survive without any of the first 9 things, but do not forget communicate with the patient. Communication is more important than diagnosis and management. Right now, in the present era, many students still have to learn the art of communication, not regarding with respect to history. Just speak what they had, food in the morning, what they are doing, how they come, everything else. So communicate to get a good diagnosis, get a good rapport. It is not your rules are not your securities that is going to protect you. The one which is going to protect you in your future practice is the communication and nothing else. Because we tend to do mistakes in our day-to-day practice. So with this, I am done for today. Thanks for your patient listening. Thanks for the opportunity given, sir.
Thank you, Sarath. It was a wonderful presentation as usual. Definitely, we VIRUDHUNAGAR people witnessed the Deepavali celebrations few months before. Thanks for all the wonderful cases and the excellent carry-home messages. Over to Dr. Kritika for final remarks.
Thank you so much, Sarath sir, for the brilliant lecture. It was so enjoyable. ரொம்ப நல்லா இருந்தது, இன்ஃபர்மேட்டிவா இருந்தது, and interactive too. And we do have certain questions in chat box.
Okay, make it
too
fast.
had asked one question. In pertussis,
yes.
why only at night? A cough,
Who
nocturnal
told?
cough, why
I didn't
only
say
at night?
only at night. The only cough that
Nocturnal cough அப்படின்னு சொல்லி போட்டிருந்தது
nothing.
இல்லையா? அதுக்கு
See, what
கேக்குறாங்க.
I used to tell my postgraduates are the only nocturnal cough, the only thing that can produce nocturnal cough is asthma. Apart from asthma, pertussis also can cause. Pertussis can also.
And then that were a heterozygous variant of cystic fibrosis. Did you do WES for parents, sir?
No, that is the recent case. The case was, we got that report only day before yesterday. Yet to do so many investigations in that case. That was the report we got day before yesterday. Many things are pending in that case. Because we didn't have clue what to offer, what diagnosis to offer. At least this heterozygous variant will make us to think in terms of heterozygous CFTR and poorly penetrated CFTR and the CRMS. So, cystic fibrosis with the one gene variants producing less severe manifestations.
Okay, sir. Sir, any other questions, sir? Venkat, sir?
No chat box.
Illa, sir. From the dozen of the cases today, we learned dozen of points. Shall I summarize quickly, sir? In any case of neuroregression, please look for vitamin B12 deficiency and think of the common causes from the community in cases of any fever. Yes. And think of the common causes like monsoon season fevers, tropical fevers, whenever there is a fever for more than 7 days. And also in the X-ray, always look beyond the heart and lung to pick up rickets. And history is very, very vital because in the pertussis case, it was the history that gave the clue. And in case of immunocompromised children, ignore the CMC copies. We need not consider it. And there is a tendency to start multiple antibiotics and multiple drugs, and always look for drug interactions whenever we are stuck up. And in case of CLE, do not stop with a single finding in a case of X-ray, and you have to look at the whole picture. And any case of non-healing ulcer, think about the neutrophil disorders. And CBs is a wonderful clue for many of the PIDs. And multi-system involvement in India, think about TB and also think about HIV. And final 2 cases told us about some importance of WES or the genetic disorders. Thank you so much, sir. Sarath sir is my senior in college. Usually எல்லாரும் born with a golden spoon, born with a silver spoon லாம் சொல்லுவாங்க. Sir, I think was born with a chalk piece and a marker, and he's a born teacher. And thank you so much for your time, sir.
Thanks for all the participants. I could notice Palani, my friend, in the audience list, as well as senior practitioner Nomani sir from Madurai. Thanks for all the participants for having joined us and made this session a lovely one. Thank you so much. Thanks, Sarath.
Yes, sir. Thank you, sir. I take leave.
Thank you, sir.
Okay.
Sure, we can
Thanks
wind
for
up the
the-
session.
Bye-bye.
Nikhil, you can.
Thank you, sir.
நிக்கில் ரெக்கார்ட் பண்ணிருக்கீங்கல்ல நிக்கில்?
ஆமா.
பண்ணிருக்கேன்.
Thank you, Nikhil. Thank you, Nikhil. Bye.
Thank you so much, sir. Thank you, everyone.
Thank you so much, Nikhil.
Thank you, ma'am.
Bye, sir.
Thank you, Nikhil.
Bye, sir. Bye, sir. Thank you.